Hi there, Dr. Holly Rizzo here. Welcome back to our lecture series in pediatric dentistry. Today we'll be discussing primary tooth treatment. So, a frequent question that we get as pediatric dentists are, when should I bring my child to the dentist? Many parents wait until multiple teeth are erupted before bringing their child to the dentist, but the AAPD recommends bringing a baby to the dentist within 6 months of eruption of the first tooth, or by age 1. This is not as much to complete a thorough cleaning, but more to provide anticipatory guidance and oral hygiene and diet instructions to protect your child's smile now and in the future. So a quick memory tip would be by the first tooth or first birthday would be the first dental visit. One of the reasons we encourage children to come to the dentist within the first year of life is for prevention. And one of the diseases we want to prevent is early childhood caries. So ECC is defined as the presence of one or more decayed, meaning non-cavitated or cavitated lesions, missing due to caries, or filled tooth surfaces in any primary tooth in a child under the age of 6. So ECC commonly affects children who sleep with their bottle overnight, and this is historically referred to as baby bottle decay, and is often seen on the labial surfaces of maxillary molars. The decay pattern often presents with first affecting the upper anteriors, then the upper molars, followed by the lower molars, and then the lower anterior teeth. If the lower anterior teeth are affected, at this point the disease has become quite severe. The definition of severe early childhood caries is any sign of a smooth surface carious lesion in a child younger than 3 years of age, and from ages 3 to 5, one or more cavitated, missing, or filled smooth surfaces in primary maxillary anterior teeth, or a DMFS score greater than 4 if the patient is 3 years old, greater than 5 if the patient is 4, or greater than 6 if the patient is 5. So how can we prevent this? To decrease the risk of developing early childhood caries, the AAPD encourages professional and home preventative measures. These mainly include avoiding frequent consumption of food and beverages that contain sugar, in particular, those that are sweetened with sugar, like juices, soft drinks, sports drinks, and sweetened tea, in a baby bottle or a no spill training cup, as well as on demand breastfeeding after the first primary tooth begins to erupt, and other dietary carbohydrates are introduced, as well as baby bottle use after 12 to 18 months. We typically also recommend implementing oral hygiene measures no later than the time of eruption of the first primary tooth. Toothbrushing should be performed for children by a parent twice daily using a soft toothbrush of age appropriate size. In children under the age of 3, a smear or rice sized amount of fluoridated toothpaste should be used. In children ages 3 to 6, a pea sized amount of fluoridated toothpaste should be used. Fluoride is safe for use in these amounts, even if the child doesn't spit, and it is recommended as soon as the first tooth erupts. We also recommend professionally applied fluoride varnish treatments for children at risk for early childhood caries. This can be offered at the child's well child visits with their pediatrician as well as regular dental visits. As previously discussed, we recommended establishing a dental home within 6 months of eruption of the first tooth and no later than 12 months of age to conduct a caries risk assessment and provide parental education, including anticipatory guidance for prevention of oral diseases. We also want to work with medical providers to ensure that all infants and toddlers have access to care, dental screenings, counseling, and preventative procedures. These providers may also be able to screen for dental caries and make appropriate referrals to a dentist who can care for the child. And finally, as dentists, it is our responsibility to educate legislators, policymakers, and third party payers regarding the consequences and preventative strategies for early childhood caries. So a child has come in and has early childhood caries. How do we treat these lesions? There are several restorative options for primary teeth, and these include amalgam restorations, composite resin restorations, stainless steel crowns, and resin strip crowns. So let's begin with amalgam restorations. One option is this, where in a primary tooth, we would recommend prepping to a depth of 1.5 millimeters with a rounded internal line angle, a flat pulpal floor, and extension into the pits and fissures with an isthmus width of 1/3 the intercuspal dimension, pictured here. Another option would be a composite resin restoration. This is generally a more conservative preparation than amalgam. Composite resin uses micromechanical retention, which involves etching, priming, and bonding. Composite resin is moisture sensitive. Therefore, it requires a dry and isolated operating field, which may be difficult to achieve, especially with a wiggly or anxious kiddo. Typically, the gingival margin is the most susceptible to failure if there's any moisture leakage. When using composite resin with kids, sometimes I'll call it tooth Play-Doh, or I'll tell them I'm putting white sparkles on their teeth to make it a little bit more fun and less intimidating. So there will be some primary teeth where the caries covers multiple surfaces and extends past the axial line angles. In this case, a composite or amalgam restoration may not be the most appropriate choice due to risk of fracture. Instead, we should opt for a stainless steel crown. So the restoration of choice for a pulpotomy, pulpectomy, or fractured primary crown would be a stainless steel crown. And as we say, this seals the deal. So when it comes to preparing a tooth for an SSC, the crown preparation is conservative with 1 millimeter occlusal reduction and enough rounded reduction that's adequate enough to break the contacts with the adjacent teeth. It's important to maintain the cervical bulge of the primary tooth as it provides retention. The preformed stainless steel crown can be snapped onto the prepared tooth so that it allows it to function temporarily until exfoliation. Sometimes small modifications may be made to the SSC, including manual crimping in order to make it the perfect fit. For children, I often call this a princess tiara or a superhero helmet. So moving on to the anterior teeth, resin strip crowns are typically indicated for primary incisors with interproximal caries or caries involving multiple surfaces or involving the incisal edge. This treatment involves adequate remaining tooth structure for bonding, and typically the caries dictates the preparation design. Generally, we recommend a 1 millimeter incisal reduction and contacts between adjacent teeth to be broken. Additionally, a celluloid crown form is trimmed with at least one vent hole on the lingual surface to allow excess composite to squeeze through while seating the crown. So now that we've discussed restorative options, let's discuss endodontics in primary teeth, as this can look a bit different from permanent teeth. Some of the signs and symptoms we'll look for in primary teeth for an endodontic evaluation include pain and sensitivity, furcation radiolucency, mobility, fistula or abscess, and root resorption. So if the caries extends into the pulp, let's discuss our treatment options. These will be dependent on the vitality of the pulp. So vital pulp treatments include indirect pulp capping, direct pulp capping, and pulpotomies, whereas non-vital pulp treatments include pulpectomy and extraction. So if the caries is approaching the pulp but the pulp is not exposed, we can complete an indirect pulp cap. During the cavity preparation, a thin layer of dentin, typically affected dentin, is maintained to prevent pulp exposure. This thin layer of dentin is reinforced with a calcium hydroxide or resin-modified glass ionomer prior to the restoration with an appropriate material. The process of an indirect pulp cap promotes the formation of a tertiary dentin, a layer of dentin between the pulp and the restoration. Again, this is a vital pulp treatment. Next, let's move on to direct pulp capping. So this is when there's a pinpoint pulp exposure either caused by trauma within 24 hours or a carious exposure of the pulp that's less than 2 millimeters. So in this case, calcium hydroxide is placed directly on the healthy exposed pulp, and it's reinforced by a resin-modified glass ionomer prior to restoration with an appropriate material. In some cases, a direct pulp cap may cause internal resorption in primary teeth. The final vital pulp therapy that we'll discuss is a pulpotomy. A pulpotomy is indicated for pulp exposures in healthy, vital primary teeth with adequate tooth structure. So in this procedure, the coronal portion of the exposed pulp is removed while maintaining the healthy remaining pulp in the canals. Once dry cotton pellets are utilized to stop the bleeding, formicresol is applied for 5 minutes before restoration with a zinc oxide eugenol and a stainless steel crown. Ferric sulfate and MTA are also other agents that may be used in place of formicresol and are less toxic and more successful, respectively. The pulp tissue in direct contact with the formicresol forms a fixed zone that is non-susceptible to enzymatic breakdown. This is superficial to the zone of coagulation necrosis, which contacts the vital tissue at the apex of the root canals. Pulpotomy is often not indicated for permanent teeth as they may induce calcification in the root canals. So going through the layers here, we would have the SSC, which is the restoration, the zinc oxide eugenol or RMGI, and then the MTA, followed by the vital pulp in the canals. Moving on to non-vital pulp treatment, we'll start with a pulpectomy. So the indication would be a necrotic tooth with enough tooth structure to still be restored. However, this is contraindicated in primary first molars due to their extensive accessory canals. In primary teeth, a pulpectomy involves complete removal of the pulp, including the canal tissue, which is then replaced with a zinc oxide eugenol material and restored with a stainless steel crown, as shown here. Finally, extractions are indicated for necrotic teeth as a non-vital pulp treatment. This is typically indicated for teeth that are non-restorable, have root resorption and furcation involvement, or restorable teeth that are very close to exfoliation. Space maintenance may need to be considered depending on the patient's age and dental development. So I've attached a flow sheet here for endodontic findings and treatment sequelae for smaller caries with no pulp exposure or a small pulpal exposure. So the first row after treatment options is the clinical event that occurs. The second row is the patient's signs and symptoms and pulpal status, and the third is the recommended treatment option. So going through it, if there's caries without exposure and there's no spontaneous symptoms with a normal healthy pulp status or reversible pulpitis, the recommended treatment is a restoration with amalgam or composite. If there's an iatrogenic or non-carious pulp exposure and there's no spontaneous symptoms with a normal healthy pulp, the recommended treatment is a direct pulp cap if it's a pinpoint exposure. If not, then a pulpotomy. If there's caries with a possible or near exposure and no spontaneous symptoms with normal healthy pulp status or reversible pulpitis, the recommended treatment would be an indirect pulp cap. Additionally, if there's occasional pain upon stimulation and reversible pulpitis is noted, an indirect pulp cap would be the recommended treatment of choice. This flow sheet is similar, but describes the sequelae and treatment options for carious exposures and gross caries. Once again, the first row after treatment options is the clinical event, followed by the patient's signs, symptoms, and pulpal status, and the third row is the recommended treatment option. So if there's a carious exposure, there are three options available. One, if there is minimal pain, no mobility, no pathology seen radiographically, and reversible pulpitis, the recommended treatment choice would be a pulpotomy. Two, if there is spontaneous pain and irreversible pulpitis, the recommended treatment choice is either pulpectomy or extraction with or without a space maintainer, depending on the tooth and the patient's age. And three, if there is the presence of a draining sinus tract, swelling, mobility, and the presence of radiographic pathology with a necrotic pulp, the recommended treatment choice is either pulpectomy or extraction with or without a space maintainer, again, pending the tooth and the patient's age. But typically in this case, extraction is preferred due to high risk of infection. If there's gross caries and there is furcation involvement, root resorption, and pathology is seen radiographically, the recommended treatment choice is extraction, again, with or without a space maintainer, depending on the individual patient. So with all that information, let's jump into a few questions. So in this question, we have a 5-year-old male patient whose chief complaint is that they have pain on the bottom right tooth since yesterday. In the background, we have a history of poor oral hygiene. Current findings, we have multiple restorations and extensive caries on the mandibular right second primary molar that's evident clinically and on the radiographs, and there's no furcation involvement. So upon preparation, the pulp is exposed to carious environment. Which is the optimal treatment for the mandibular right second primary molar? Take a moment to pause to think about this question. So the correct answer to this question would be option E, which is a pulpotomy and stainless steel crown. So this patient has extensive caries on the right second primary molar, and there was a carious pulp exposure. It does not specifically say pinpoint, and a direct pulp cap is not an option in the answer choice. So the best answer is a pulpotomy and SSC. For our second question, each of the following criteria are required for an amalgam preparation in primary teeth except one. So take a moment to pause and think about this one as well. So the correct answer to this question is option A. The isthmus width of an amalgam preparation should be 1/3 the intercuspal dimension, not 1/2. So to summarize today's discussion, the first dental visit should be made by the first birthday or by eruption of the first tooth. Restoration options for caries include amalgam, composite resin, stainless steel crowns, and strip crowns. And treatment options for pulpal involvement in primary teeth include indirect pulp capping, pulpotomy, pulpectomy, and extractions. So thank you so much for joining us, and we'll see you next time in our lecture series in pediatric dentistry.